So good afternoon, everyone. In today's session, we are going to talk about the high yield questions which have appeared in the previous MRCP Part 1 exams. And this time we'll concentrate on the section of diabetes. And as I had mentioned previously in my video, these are all high yield questions which have appeared in the past papers and recalls from the past MRCP Part 1 exams. So let's start right away. So question 1, we have a 50-year-old male, type 2 diabetic. He's a long-standing diabetes for last 10 years, has developed diabetic maculopathy, and is going to require pan-retinal photocoagulation. Patient should be counseled about what possible side effect. Options are central visual loss, floaters, conjunctival redness, and impaired nighttime vision, or corneal ulcer. So a patient going to undergo pan-retinal photocoagulation, what possible side effect is the patient needs to be counseled about? So try to solve this MCQ. Correct answer here is impaired nighttime vision. So laser treatment aims to prevent further visual loss, especially in maculopathy. However, it's important to note that it does not restore the vision. The benefits from laser therapy currently outweigh any risk. What are the possible risks? Accidental burns to the fovea if the eye moves during therapy. Second, reduction in the nighttime vision, which was the answer for our question. Third, interference with the visual field defect, like visual field, severe enough to affect the ability to drive. However, this only happens in a very minor and very small number of patients. Question number 2, we have a 45-year-old male, type 2 diabetic. Recently, he put on a flash glucose monitor, and because his glycemic control was suboptimal. He's specifically noticing that his blood sugar is spiking after dinner beyond the range recommended by his doctor, and wanted to identify which of the following food or food products which he commonly eats in his dinner is responsible for this spike. So the question is, which of the following food or food products is having a high glycemic index? Options are cooked carrots, proso, white rice, porridge, or whole meal pasta. So they have asked about which of this product, food or food product is of high glycemic index. So the correct answer here is white rice. See, white rice almost has a glycemic index of more than 70, and that's why it's come in the high GI index food. So what is a GI index? It tells us how fast a food or a drink affects our blood sugar levels. Foods we digest slowly release glucose into bloodstream gradually, and they have a low GI value. Foods which we digest quickly release glucose in the bloodstream quickly and have a high GI index. So the GI index is a scale from 0 to 1 to 100, and glucose as a reference point has a GI of 100. So we can compare all other foods against this score. Low GI index foods are having a GI index of 55 or lower. Medium GI index foods are having a GI index of 56 to 69. And high GI index foods have a GI index of about 70, like white rice. So question number 3, here we have a 32-year-old male, type 1 diabetic, admitted to the hospital with pneumonia. His pre-admission insulin regimen was as follows. He was taking the basal insulin in the form of insulin glargine, 34 units at bedtime, and insulin Lispro, short-acting, he's taking 6 units, 10 to 15 minutes before each meal. On the afternoon of the second day of his admission, he reportedly felt sweaty, clammy, shaking, and his blood glucose was found to be 2.6 millimole per liter. He's fully conscious though. So what is the next immediate action we should be taking in this regards? Of course, to correct his hypoglycemia. Should we give glucosamine 100 to 150 ml? Should we give 2 tablets of dextrosol followed by 2 biscuits immediately? Should we give 7 tablets of dextrosol followed by biscuits when BM is more than 4 millimole per liter? Should we give intravenous dextrose 10%? Or should we reduce his morning dose of short-acting insulin? So here the problem is happening in the afternoon time. On the second day of his admission, he's hypoglycemic. So what is the possible you need to give to correct his hypoglycemia? The correct answer here is based on the JBDS 2023 guidelines, which clearly states that in this case scenario, where the patient is conscious and hypoglycemic, gives 7 tablets of dextrosol followed by biscuits when the blood glucose has come up to 4 millimole per liter. And this is the algorithm which they have advised. So in mild cases of hypoglycemia, like our patient, those are adults who are conscious, oriented, and able to swallow. In this case scenario, when the blood glucose is below 4, check the ABCD first, stop IV insulin infusion if running, give 15 to 20 gram of quick-acting carbohydrate, such as 5 to 7 dextrosol tablets, which was the answer in this question, or 4 to 5 lift glucotabs, or 150 to 200 ml of pure fruit juice. Again, we test the blood glucose after 10 to 15 minutes, and if it is still less than 4 millimole per liter, repeat the treatment above. This can be done up to 3 times. If still hypoglycemic, call the on-call doctor, and in this case scenario, we'll have to consider IV dextrose or IM glucagon as per the severe pathway. Going further on this mild pathway, and now this is true for all, for the mild and the moderate pathway, check blood glucose after 10 to 15 minutes. Once blood glucose levels are now more than 4, give 20 gram of long-acting carbohydrate like 2 biscuits. So that was the other thing in this question stem. In this answer, 2 biscuits, or we can give a slice of bread, or we can give 200 to 300 ml of milk, or we can give the next carbohydrate containing meal. We may need to give a higher dose, like 40 gram, if IM glucagon has been previously used to correct his hypoglycemia. For patients with enteral feeding tube, we give 20 gram quick-acting carbohydrate via enteral tube. Example, 50 to 70 ml of Ensure plus juice or 40 juice. So this principle for maintaining the blood sugar is followed for both the mild and the moderate pathway. Severe pathway is a little different. We'll talk about that in the other part of this chart. So what about moderate? So if the patient is conscious and able to swallow, but confused, disoriented, or aggressive. So this can easily be another MCQ for the exams. So in this scenario, where there is a moderate degree of impairment in terms of the hypoglycemia, patient is confused, disoriented, aggressive, again check ABCD, stop IV infusion, insulin infusion if running. If capable and cooperative, treat as for mild hypoglycemia. If not capable and cooperative but can swallow, give 2 tubes of 40% glucose gel, squeeze into the mouth between teeth and the gums. Again, test blood glucose after 10 to 15 minutes, and if it is still less than 4, repeat this up to 3 times. If still hypoglycemic, call the doctor. Consider IV dextrose or IM glucagon as per the severe pathway. Now, what is the severe pathway? If the patient is unconscious, fitting, or very aggressive, or nil by mouth, then check ABCD, stop IV insulin, request medical support urgently. In this case scenario, we need to give the patient 100 ml of 20% dextrose or 200 ml of 10% dextrose over 15 minutes. Both these things are extremely important to note for the exams, repeatedly asked in the MCQs in the MRCP exam. If IV access is not possible, use 1 milligram IM glucagon. Recheck the blood glucose again after 10 to 15 minutes. If still less than 4, we need to repeat the treatment as above. If glucose down 4 millimole or above, follow up treatment as described on the left side. If NBM, once glucose is more than 4, give 10% glucose infusion at 100 ml per hour until no longer NBM or reviewed by the doctor. Some important things to note that we should never omit subsequent insulin doses. Make sure that we are continuing the blood glucose monitoring for 24 to 48 hours after this. Review insulin and or hypoglycemic doses or hypoglycemic. If previously on IV insulin, they will generally consider restarting insulin once blood glucose is more than 4, but may require a review of the regimen. Glucagon may take up to 15 minutes to work and may be even ineffective if treating hypoglycemia in undernourished patients, in severe liver disease, sulfonylurea-induced hypoglycemia, and in repeated hypoglycemia. So a very important algorithm chart from the JBDS guidelines. Each and every part of this chart has come as MCQ in the previous exams as well. Moving on to question number 4, we have a 55-year-old male seen in the clinic complaining of pain in both the feet. This pain is predominantly burning in nature, worse at night, is often severe, and he tried some vitamin B complex to get relief of it without any benefit. He's a type 2 diabetic male. His latest HbA1c is uncontrolled at 8.5%. He's currently on metformin, dapagliflozin combination therapy. His BMI is 27, so it's the overweight category. On examination, he does have normal power bilaterally, but has reduced sensation to the 10-gram monofilament examination. Pedal pulses are present. There is no skin-related changes. So what is the most appropriate first-line treatment for this kind of a pain? By now, of course, you must have guessed what this patient is suffering from. So what are the options to manage his diabetic neuropathy? Is it naproxen? Is it duloxetine? Is it codeine? Is it topical capsaicin? Or is it tramadol? So the answer is duloxetine as per guidelines. So these are from the NICE guidelines, which clearly suggest guidelines for the management of neuropathic pain in adults in all cases of neuropathic pain, even for diabetic and even all the other cases of neuropathic pain. So the guidelines suggest to offer a choice of either amitriptyline or duloxetine or gabapentin or pregabalin. So any one of them can be used as the first line management for the neuropathic pain, except in the pain related to trigeminal neuralgia, where carbamazepine is a drug of choice. If the initial treatment is not effective or is not tolerated, offer one of the remaining 3 drugs and consider switching again if the second and the third drugs tried are also not effective or not tolerated. So very simple, the choices are between amitriptyline, duloxetine, gabapentin or pregabalin. All are first line. Next is consider tramadol only if acute respiratory therapy is needed. Last but not the least, consider capsaicin cream for people with localized neuropathic pain only who wish to avoid or who cannot tolerate oral treatments. So the correct answer here, which is the first line drug, which is duloxetine. Question number 5, we have a type 2 diabetic 51-year-old male presented to the clinic for review, currently takes metformin only for his diabetes and reports the following he recently has recovered also from a non-ST segment elevation MI. His HbA1c is 63 millimole per mole, which of course we know the target is less than 53 millimole per mole, and the clinician and the patient decide that he should start and SGLT2 inhibitor because of its benefit in post-MI patients as well, in addition to his metformin. So which of the following best describes his new treatment options mechanism of action? So we are talking, they have asked about what is the mechanism of action of SGLT2 inhibitor. So these are the options. Does it increase stimulation of insulin secretion by pancreatic beta cells and decrease hepatic clearance of insulin? Does it inhibit the sodium glucose co-transporter 2 in the proximal convoluted tubule of the nephron to stop glucose reabsorption, meaning it is excreted in the urine? Does it inhibit the principal enzyme that breaks down GLP-1, an incretin hormone that increases the insulin secretion and suppresses glucagon secretion? Does it reduce hepatic gluconeogenesis, increase peripheral glucose uptake, and reduce absorption of carbohydrate in the gut? Or does it cause upregulation of the transcription of the insulin responsive genes, leading to an increase in the glucose transporters and insulin receptors at the surface of the cell? Correct answer is, we already have a clue with the option itself, inhibition of the sodium glucose co-transporter 2 in the proximal convoluted tubule of the nephron to stop glucose reabsorption, meaning it is excreted in the urine. So this is important, even it is at the level of the PCT. So again, important to remember for the future exams as well. Option A best describes the mechanism of action of SU. Option C describes the mechanism of action of DPP4 inhibitor. Option D is for your metformin, and option E is for pioglitazone or TZDs, thiazolidinol. So that's the end of today's session. If you liked the session today, please like our lectures. Please leave your comments below, share with your friends and colleagues, and do subscribe to our MRCP channel. Thank you so much.